So our next talk is kind of going up in the age spectrum again, and we're now going to be talking more about adolescents and patients who may be at particular risk for opioid misuse. It's my great pleasure to introduce Dr. Lucien Gonzalez, who is a pediatrician and addiction specialist at the University of Minnesota. He's an associate professor in the psychiatry department and has been an active member in the Committee on Substance Abuse Prevention. Also an avid biker who's going to be heading to Costa Rica for a bike race right after this meeting is over.
Perfect. This is definitely going to be a shift in gears. So do you guys all remember about 20 years ago, there was a public service announcement around colon cancer screening, and it was this old middle-aged white doctor in a white coat, and he stands there like this and says, run your hands down your back. If you feel 2 bumps, you're at risk for colon cancer. And there's, right? And a lot of people laughed. It got a lot of people's attention. There was also, interestingly, a lot of guff about it. Like, well, that's not entirely accurate. The whole point about it, though, right, was that not that the bulk of people don't have it, but enough people have it, and the reason that they cast the wide net of a screen that they do is to catch people at the right time during illness as possible. And so that was what came to mind for me with this. This is the way I avoid copyright infringement. The biggest risk factor for developing an opiate use disorder is having a human brain. So we'll talk a little bit about things that enhance the risk and groups that are at higher risk than others. But at the core of it is there's things about having the brains that we do and the responsiveness and the circuitry that responds to opiates in a particular way and other substances that support addiction. So while we get all nerdy about these different things that might enhance somebody's risk by like 15% or something, it's to make sure that we remember some essential key elements, which is about being human, and that we're kind of built to respond to a lot of these substances. And some of us at different times, because of different hits that come at the right time, we'll develop a problem, but at our core, I mean, there'll be a lot of drinking that goes on while people are high. There's a certain amount that's considered acceptable, that's part of a life that can be maintained, but at some point, just about every substance that somebody can get exposed to, they could develop a problem with. So it's also a reminder to kind of humble ourselves a little bit and kind of self-reflect when we kind of start to hear the tone change and the words that get used depending on how mad people are, wanting to seek blame for where this problem is coming from or might be the cause, is to kind of, and I remind that to myself as well, to kind of check myself with where my thinking is at when I consider some of the questions that I'm putting together and how I'm proposing solutions. The other thing I want to talk about related to that has to do with a base rate fallacy. Again, when we start to talk about trying to find out who's going to be most at risk for doing bad things with their prescription or who's going to be most vulnerable or at risk to develop a problem, it's important to remember things like base rates. And so things like depression and anxiety do enhance somebody's risk for using substances and developing a substance use problem. On the other hand, most people don't have depression and anxiety. Most people who have those problems don't develop substance use issues. When you have somebody with an opiate use disorder, we frequently don't find another DSM diagnosis to have to give them. That diagnosis alone also, by the way, is a psychiatric problem. So this is my waxing poetic a little bit. I'm really sick of the dual diagnosis thing. We still somehow have mental health and addictions or this and that. It's a bona fide psychiatric problem plus that. It's actually all part of the same thing, and we'll talk a little bit about that. And by separating them out, it's actually contributed to the ways in which we've perhaps not characterized some of these issues scientifically accurately, and some of the solutions that we proposed may not work as well because of this need to kind of silo it out and separate it from the rest of mental health. People have seen this slide before. It doesn't change. It begins with one pill. Well, we've made some strides in terms of reducing some of the overall prescribing, including to kids. We don't need to have a prescription supply to continue to support their use. They just need a taste. And you heard it discussed that how kids get exposed in the first place is often through somebody else's prescription or their own. And so there are many other supplies that kids can access after they've been exposed. And so as long as we continue to have any type of supply out there, including what they get exposed to both legitimately and not legitimately. It's the exposure that we have to think about. And so that even with reducing the amount that ends up prescribed, exposure is still a risk. No raising of phones. This is just a thought. Just read it as to make a point. Definition is of non-medical use that a lot of us use. Number one is use of a prescription opioid that's diverted from somebody else's prescription and or using from your own supply in a way that was not intended by the prescriber. And so the point here is when initiating use for the first, non-medical use for the first time, most of the time still, kids are not getting it from the internet or from dealers. They're getting it from either a family or friend's prescription or their own leftovers. And in addition to having leftovers, the amount of kids who are left unsupervised with their medications as well, that not having an adult supervising and securing that med still occurs at an alarmingly high rate. And so that leaves them with opportunity to experiment with those medications later. After a kid or somebody else has developed a problem with opiates, then there's opportunity to avail themselves of dealers, of internet, of the dark web, and at some point turning to heroin. You had mentioned the first wave of heroin in the United States being in the 70s. The second wave, which started in about the early 2000s, for a while in the beginning, the proportion of people who started opiate use started with prescription opioids and then transitioned to heroin. What we're starting to see is minor shifts among the young populations coming into treatment now. It's still predominantly prescription opioids, but a lot of them, the first opiate use that they have is actually heroin. So something to keep in mind. So exposure itself does confer some risk. This is legitimate exposure. Say a kid has a tonsillectomy when they're 7 and gets prescribed it. At some point later, as a group, there's enhanced risk for non-medical use at some point in emerging adulthood. And at first that sounds really freaky. Oh my God, is that every kid? No, again, it's not most kids, and there are certain factors alone with it. So it's exposure alone is not enough. And two major things come out when you think about, when you're looking at the kid who has a prescription when they're younger, and then say at 19, uses non-medically for the first time. Other substance use are acceptable highs of alcohol, nicotine, and cannabis always get in there before they go back and experiment with opiates on their own. The other thing is, while not complete, is intention with their use. Whether they've been primed by other substance use in between or whatever happened, the kids who are taking it purposely for the experience that they're trying to have, it could be a high, it could be to relax, it could be to de-stress, to be less depressed, whatever it is. But if they're looking for some CNS reinforcing properties from that, that's a kid who's also gonna have riskier use with that and also have increased likelihood to go on to develop an actual problem. The other thing, bridging more and more generally into psychiatric health, unfortunately, what we've seen, are starting to see in the adolescent population that was established in adults, is that groups that are considered more at risk, particularly adults with anxiety and depression, then showing up in the emergency department or other acute medical situations with non-malignant pain, back pain, neck pain, headaches, things like that. Of those adults, and now we've seen it with kids, is that the kids who have prior diagnoses of anxiety, depression, are more likely to receive opioids and then more likely to go on to chronic opioid prescribing exposure. And the longer they're exposed, the more likely they're going to be at risk to develop a problem. So it's another way, in addition to the amounts that we give out, is really looking at some of the populations that get it. We are part of contributing and putting people who are already at risk at more risk. The other thing I want to point out is identifying misuse risk is not enough. So there's been a lot of effort at trying to pinpoint, again, predict who's going to be most likely to have it happen and have a problem, and picking them out. And a couple of problems with that. One has to do with when future use might become a problem or might be outside of that window. So it makes us feel better, but that doesn't help the kid. The other, again, is to understand, basically to not say hyper-focused on one substance. And we've been focused on opioids for quite a while, but what else is creeping up? Methamphetamine, e-cigarettes, cannabis, I can tell you, is going to be having a huge wave once big tobacco is able to be involved in the United States. And so it's keeping in mind that the roots of this problem, part of it for kids is exposure to other substances, and part of the solution, which I'm giving you a little hint about where things are going, is making sure that we're working much, much earlier in terms of looking at substance use that occurs before then and the other problems that contribute to developing a problem. So what does make non-medical use more likely? I'm going to say it multiple times. Other substance use, other substance use, other substance use, and the presence of a substance use disorder. Other mental, psychiatric symptomology, peer group that's using substances, the experience of chronic pain, which I'll make a couple more comments on, and experiencing discrimination of any kind, whether it's racism, homophobia, ableism, I'll talk a little bit about that as well. Any type of discrimination contributes to that. What seems to globally maybe reduce the likelihood of non-medical use? One is a greater perception of substance use risks. We'll talk about that. Strong parental bond, parental disapproval of substance use, which is sometimes actually really hard to mediate. You were talking about the generations of it. I have a lot of patients right now whose parents are deeply involved in receiving chronic opioids. There are just family structures, family constructs where they have been medicalized into receiving opioids chronically, and that's the setting in which a lot of these kids are growing up. And so they may disapprove actually of their kids' use, and they often want them to get help, but it's remembering that sometimes, having this type of context in terms of what the parents are actually doing, you may not be so lucky to have that. The other is just in general support, such as having a gay-straight alliance for protect sexual minority youth from non-medical use. And getting to perceptions of risk. Brains don't differentiate between whether or not substances are legal or not, but young brains do. And when it comes to prescription opioids or any prescription drugs, they still have this ridiculous mindset that it's safer if they're taking pills than if they're using, say, heroin. And same thing now with cannabis. As more and more states are moving towards recreational legalization, it's also influencing their mindset. And I'm mentioning cannabis for a reason, and I'll bring that up again. So again, looking at hammering some of the risk factors. Of this list, it's actually D, identifying as Black is not a risk factor for non-medical use. And putting this up here to highlight the fact that this is actually predominantly, historically, it's a white problem. On the other hand, people of ethnic and racial minorities get the short end of the stick in terms of how they're affected by overdose, their access to treatment, and what happens to them now with these foster care placements. And so yes, heroin use in particular has been related to a lot of out-of-home placements. On the other hand, a lot of Black and Native American families, their children have been taken out at a disproportionate rate, even when their risk scores are established to be lower than for white families. So like I said, even though proportionally this has been affected white populations more, racial and ethnic minorities are getting hit harder by the negative impacts and by lesser access to treatment service, including medications. The other thing I wanted to point out here is bringing in the issue of chronic pain. Part of what we were talking about with some of these prescriptions is trying to avoid the use in cases where they clearly don't need opioids. As a lot of people in this room know, there are a lot of kids with chronic health conditions where you may be able to limit it, minimize it, but we're not going to be able to 100% prevent exposure to opioids. And so the experience of chronic illness, the experience of chronic pain is going to continue to be a risk factor both for some of the mental health morbidities, but also because of opioid exposure, it just is a risk factor that we're going to have to deal with. And I just threw in here for D, Hispanic is also not a group that's a risk factor. It's being white that's a risk factor. And I also put in here exposure to trauma for a reason. Oftentimes when we think of trauma, it's going to be physical abuse, emotional abuse. When it comes to, particularly for kids with chronic illness, it's remembering medical trauma. And I've found a lot during doing inpatient child psychiatry consults that there seems to be a way in which a lot of times as a culture that we try to kind of not only separate ourselves from the impact that often necessary interventions that we expose kids to, that we somehow want to deny that because we needed to do it, that they are not hurt by the thing that's helping them, and they are. And as you know, a lot of kids and families are very resilient and seem to come through unscathed, and some kids are vulnerable and have a harder time with it. And what I've often found is rather than treating it and, as I say, making a case formulation that puts it in that context, they often end up sort of partition that out and say, well, this kid's got depression, come see him. Rather than us coming together and seeing that we need to take care of that in light of the experience that, like I said, our helping them has caused some hurt that we need to be able to treat together and not just otherwise pathologize the kid and sort of dismiss our part in it. This, again, is to highlight the exposure of kids with chronic conditions, many times necessarily to opioid medications. Part of why I put this in here, too, is in terms of ableism, number one is what I call screening, pre-screening. When we decide by looking at a kid that they're not the one who's going to have a problem because that's a bad kid somehow, or they wouldn't do this to me. And a lot of kids get overlooked in where things have gone in terms of the use or the impact of meds on them. And then when they do need help, we often overlook, especially for kids with neurologic or developmental disabilities, of having care that's appropriate that they can participate in. So again, the impacts of ableism are felt everywhere. The other thought comment I want to put out there is, what are we treating? People who are familiar with the DSM will see that we still treat things or kind of characterize things categorically. It's a checklist. It's how we end up with multiple comorbidities. Check, 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 you've got depression. Check, 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 you have opioid use disorder. And it's probably a little bit more accurate to say that things are more of they're messier than that. And people are starting to look at things transdiagnostically. And why I mention this about opioids in specific, a lot of science right now is directed at trying to kind of tease apart the mysteries of opioidergic mechanisms in terms of how they underlie emotion regulation normally and cognition. And there's some thought, particularly with the kappa and mu systems, that not only that it might play into sort of normal function, but also the occurrence of depression for some people. And wouldn't it be interesting if in some way we're triggering some people to have, say, depression or anxiety symptoms by being exposed to opioids in the first place? We didn't do it to them, but there's a sort of a triggering, as it were, by exposure. And it may be necessary exposure, but it really changes the paradigm when we start to see all of these things as together rather than just completely separate from each other. It's messy. It's not just a checklist, even though we would like it to be that. And so unraveling these mysteries is not going to be solved with silos. And we all live and function in silos, and they're deadly. One has to do with, like I said, with diagnostic silos. Keeping them separate is probably not really helpful scientifically in terms of characterizing these issues. Second is these developmental silos that we have. Sometimes people who are focused on the prenatal period, neonatal abstinence period, adolescence, usually when people ask me what I do, is like, oh, you talk about teenagers. It's like, no, I think lifespan, and then adult. And how things can impact kids negatively is when we stay just focused on one piece and are not able to see downstream events of some of the interventions that we may be applying in one place or another. So, and also making sure that we learn from what we're doing in one developmental area versus another. The other is treatment sources. A lot of substance use treatment is completely separated from the rest of psychiatric care, from the rest of medical care, and from resources, not only the community, but the cultures that people come from that are otherwise there to help promote people's health and spirit. When all of those don't come together, we're not helping people quite as much. And one of the biggest silo busters there is for children and families are pediatricians. And I'm gonna make a case in a couple of seconds about why screening and brief intervention and incorporating that into practice, whether you're a subspecialist or whether you're in primary care, is a critically important part of doing this. First, and I'm hoping that why you'll do this, number one, is for the potential for prevention. Number 2 is to maintain their medical home. And number 3 is because if we don't do it, nobody else will. You may not be the source of these medications, but you need to be the source of the education. You may not be the source of the medication, but you need to be the source of the person who picks up issues, early issues regarding substance and early issues regarding their psychiatric health. The other, and I'm glad you mentioned this as well, was education. That these are medications that there was a reason that we exercised such control over them a long time ago. The capacity for them to cause addiction problems are so huge, and there are other negative sequelae that he pointed out for kids that are short of addiction, that it's really important that parents know up front. And even if we're the one that tells them, and it's not the dentist, and it's not the surgeon, and it's not the person in urgent care that tells them, that we guarantee that somebody is giving that family and that kid, when it's appropriate, the education to understand some of the downsides of these medications. I have no disclosures. There are 2 projects, because I want to give you support for those who have not made movement towards incorporating screening and brief intervention into their practice. There's an existing online QI module that is free to you if you're an AAP member. And I'm part of faculty on that. And then secondly, this is one that's currently ongoing. This is Project ECHO. It's a telementoring program where we're working with the first of 4 cohorts. These are pediatric practices across the country. And why esport? Because you're like, this is substance use. What we're finding with this cohort is people are going exactly where I'd hoped they would go. Yes, they're screening for substance use, and what they're figuring out is, and part of this process is, because they know the family and because they're learning about what else is going on for this kid behaviorally and psychiatrically, and they're already taking care of them medically, they're beginning to figure out how they want to help manage in the pediatric medical home these complex cases. And so it's like I said, it's doing it with support. The EQUIP is an online, just the online module. This one you get to work with practices across the country as well as our faculty support. And the people, Shannon and Eileen, I spoke with them. For anybody who's interested in doing this, they are gonna have recruitment for the next cohort sometime in November. Please feel free to email either one of them or email myself if you have questions about how it's going and what it's about and what time requirement that you would have. And that is what I've got, references.